Treatment of heart failure in pregnancy. Yes, heart failure can be safely treated in pregnancy. Good morning and welcome to today's episode where we learn how to manage heart failure safely in pregnancy. Pregnancy puts the heart under immense stress, and when heart failure occurs, prompt specialized treatment can save both the life of the mother and the baby. And the goal is always, number one, maternal safety, maternal stabilization, and number two, fetal safety. So how do we manage a lady? Principle number one, the care must be team-based. A pregnant woman with heart failure should be managed in a high-level facility with a pregnancy heart team. The pregnancy heart team comprises of a cardiologist, obstetrician, a maternal-fetal specialist, a anesthesiologist, and a neonatologist. This team approach lowers complications and ensures safe delivery planning and safe management both of the mother and the baby. So what medications do we use to manage heart failure in pregnancy, and what should we avoid? So the drugs that are safe in pregnancy include, number one, diuretics, furosemide. This helps to relieve fluid overload. It reduces breathlessness, but you need to monitor your electrolytes and the maternal blood pressure. Class number two is beta blockers. Among the four pillars of heart failure, beta blockers are the only drugs that are safe. Metoprolol, bisoprolol, labetalol. They protect the heart, they control the heart rate, and you need to monitor the maternal BP and also the fetal growth. Class number three is hydralazine and nitrates. This lowers the heart stress safely, especially when you cannot use the ACEs and ARBs. Digoxin. Digoxin is used with low ejection fraction. It improves heart rate, heart contraction. It has symptom relief and controls the heart rate, especially with atrial fibrillation. Anticoagulation is also very important. Pregnancy is high clot risk. With PPCM, atrial fibrillation, you need to put anticoagulation, and we mainly use low molecular weight heparin. What are the drugs to avoid in pregnancy? Among the four pillars of heart failure therapy, ANIS, ACE, ARBs, beta blockers, MRAs, SGLT2s. Only beta blockers are safe to use in pregnancy. The others must all be avoided because they can harm the baby. So ACE inhibitors, ARBs, ANIS, your sacubitril valsartan, they are teratogenic and should not be used. They cause fetal kidney damage, so that pillar one should not be used in pregnancy. Mineralocorticoid receptor antagonists, your MRAs, spironolactone, it should also not be used. They may affect fetal hormonal development. SGLT2 inhibitors, dapagliflozin and empagliflozin, there is insufficient data in pregnancy, should not be used. Statins, if the mother was on cholesterol medications, they are also teratogenic and should not be used. Among the anticoagulants, warfarin should not be used, especially in first trimester. It can cause fetal malformations. The DOACs, levaloxaban, apixaban, dabigatran, should also not be used in pregnancy. Note, many of these medications can be restarted postpartum based on maternal needs and the breastfeeding plans. So for heart failure in pregnancy, you use your diuretics, your beta blockers, digoxin, hydralazine, and anticoagulation, preferably with low molecular weight heparin. Special mention of peripartum cardiomyopathy. We learned about PPCM on Monday, that mothers can develop heart failure in the last months of pregnancy up to 5 months post-delivery. Peripartum cardiomyopathy, and there is no underlying heart condition. Treatment is similar as I have mentioned above. You use the standard heart failure therapy, diuretics, beta blockers, digoxin, hydralazine, and anticoagulation when indicated. But bromocriptine, a drug that blocks prolactin, has been found to be of benefit. Prolactin is a hormone implicated in worsening heart muscle damage in PPCM. So you may use bromocriptine in PPCM, but this requires stopping breastfeeding and specialist control. Remember, heart failure in pregnancy is treatable. Early diagnosis. The Pregnancy Heart Team Safe Medication gives both the mother and the baby the best outcome. The safe drugs for heart failure in pregnancy include diuretics, your beta blockers, hydralazine can be used, digoxin, and anticoagulation. Avoid the other pillars of heart failure therapy: ACE, ARB, ANI, MRAs, SGLT2s. So heart failure in pregnancy can be treated safely. Please stay tuned for the final episode of Heart Failure in Pregnancy, where we discuss delivery planning. What is the safe option for delivery with a mother with heart failure in pregnancy? What is the postpartum care? What care do you do after delivery? And future pregnancies, can you still get pregnant after you have had heart failure in pregnancy? So do not miss our final episode of Heart Failure in Pregnancy. Keep your questions coming and I will answer them as we go along. Dr. Beatrice Muthui-Mutua, saving lives one heart at a time.